Hi everyone, I'm here today to talk to you about coagulation. So this first video is going to be on the coagulation process. The second video is going to be on the medications that we have to help when someone already has a blood clot. Some of the causes of blood clots can be seen here post-op. Patients are at risk. Patients obviously that have a past history of DVTs, heart failure, atrial fibrillation, contraceptives have a side effect of blood clots, and cancer patients. So let me show you here let's just talk about atrial fibrillation for a moment. Here's your heart, here is your aorta, and here is your left atrial in fibrillation. So we're looking at the left atrium right now. There's an appendage on your left atrium that when the heart does this fibrillating kind of a quivering sensation, it doesn't pump very well, so it doesn't pump all of the blood out of your atrium into your ventricle. And so it kind of accumulates here and starts to move over to this little appendage where it can become stagnant. And this is where a blood clot can form. Then, if a patient goes from atrial fibrillation because they're on medications and they go straight into normal sinus rhythm and the heart gives a nice pump here, a nice push, then it can actually push this small blood clot down into the ventricle where then it can go and circulate throughout the body. And that blood clot is going to stop wherever there's a diameter resistance for it to stop and can cause major damage. Okay. So a lot of these medications that you'll be given are to either prevent DVTs from happening, post-op, just immobility in general, and immunocompromised patients, cancer patients. But so many of them are also on this for either the atrial fibrillation or they are at risk for atrial fibrillation because heart disease can cause atrial fibrillation. And so most of the time, a lot of these medications are either prophylactic or causing or treating a problem. We do have our body's own defense system to either clot and to dissolve a clot. So our own body has platelets, which are great because it stops us from bleeding. It clots right away. It's a very fast process. And then we have our coagulation cascade, which coagulates our blood, which also stops bleeding from occurring. It's just trying to protect ourselves. Our own body is trying to protect us. And then clot dissolution, our own body actually produces TPA, which we'll talk about in a moment, and that is circulating in our body all the time, and it is doing fibrinolysis, which is breaking down the fibrin, which is inside a clot, which then helps it break down. Platelets or thrombocytes. So platelets are immature cells in the blood bone. They are stimulated by thrombopoietin hormone, which is synthesized in the liver and kidney. So when you have a patient with liver or kidney problems, you might see a lower platelet count. And these lab counts all need to be taken into consideration when we're talking about platelet medications. The thrombopoietin itself, the hormone, regulates the platelet values. Their lifespan is 7 to 10 days, but a third of them actually reside in the spleen. So that's why when you get spleen damage or it has actually been open, maybe from trauma, you can bleed a lot. You can bleed out and lose a lot of blood if you have spleen issues. So coagulation itself is an aggregation. So it's an aggregation of platelets and forming of fibrin to make a clot. As you can see in the picture here, whenever we have like an injured endothelium cell, if it's broken or torn or something, then the first response is to bring platelets to adhere to those granulations. Okay, so once that happens, we get trauma and damage and we get an inflammatory response. Prothrombin is in this. We're going to talk about the coagulation cascade in a minute. So our prothrombin is released, and that draws platelets to the injured site. They stick together, they're very sticky. And that particular process, then the aggregation, we call a platelet plug. So platelet plug, aggregation, think of them as the same word. And that is primary homeostasis. The secondary homeostasis of the coagulation stimulates the prothrombin to form thrombin, and then fibrinogen to form fibrin. Now, fibrin, what that does is it binds all in there with um, think of like threading a needle through something and making it stronger and stronger. That's basically what the fibrin does to a clot. So you've got your clot, you've got your platelets, and then the fibrin comes in and makes it stronger. And that's all due to our coagulation cascade. So as you can see, I spoke earlier about fibrinolysis, about breaking down the fibrin to help get rid of the clot. And so that's what we want to do, is try and get rid of the fibrin. Only some medications will do that, very few will. So remember this lovely coagulation cascade from A and P. You don't need to know all of it, but you need to know a few things. And it's more so about an understanding, because the understanding of this cascade and how it works a little bit will help you with the drugs and the medications and understanding how they work and why we use them. So this is the pathway, and it goes basically all the way from, trauma or some damaged surface. And remember, we said we got some inflammation and everything in here. Okay, it all comes into factor XA, where this is really what we're looking at here is, sorry about that, guys, is the prothrombin. This is where we're going to really start the prothrombin to the thrombin, and then the fibrinogen to the fibrin to make it really strong. Okay. These are some major medications that we use. We use enoxaparin, otherwise known as Lovenox. What that does is it works on factor XA um, and the thrombin. So factor XA and the thrombin. And basically all it's doing is this is not breaking down a clot. All this is doing, enoxaparin, is trying to help prevent that clot from getting bigger. Because remember, I told you we have our own TPA, our own um, fibrinolysis in our body to help it become dissolved. So these medications only stop it from growing. Okay. The next medication is heparin. Enoxaparin actually is a derivative of heparin. It's a low molecular weight heparin. So what you'll see in a moment is we have labs that we can help determine clotting times, but with enoxaparin, we don't use labs. It's usually weight-based, and we don't get a real true accurate reading with enoxaparin because it's so low molecular heparin. But when we get to heparin, which is a little bit more concentrated, we do have labs. So heparin uses the extrinsic pathway. So here is the extrinsic pathway right here, which means it's very fast. Okay, we measure heparin by the PTT or APTT. Normal clotting factor is 26 to 32 seconds. This comes into play, this clotting factor. Remember, this is our clotting factor here. If we have a trauma and it happens fast, to bring those platelets and end up with fibrin to make it strong. So our heparin, we want to try to stop that from happening, or we want to prevent it from getting so strong. So we use heparin as a kind of an antidote for our own coagulation process, basically, and it works with this extrinsic factor or pathway. Um, it blocks the prothrombin from thrombin, so it tries to block right here so that the prothrombin never turns into thrombin, and then we can kind of halt all of this fibrin and fibrinogen so it doesn't get stronger. Our coumadin is part of our intrinsic factor, and we measure coumadin in two ways. Here I've just shown you PT, but what we truly measure heparin with is the INR. And we're going to get to that in a moment. INR, let me put INR in here. INR is a derivative of PT that is best to measure the clotting factors for coumadin. And a therapeutic range for INR is 2 to 3.5. This is the therapeutic range. That means that that is when it is working the best. Okay. This interferes with vitamin K formation, and it also blocks the conversion of prothrombin to thrombin. Vitamin K is going to be important because these all have antidotes that we'll talk about. Or I might as well tell you now. Coumadin, think my little trick is to say out coumadin in phonetics. So coumadin, vitamin K. So vitamin K is the antidote for coumadin. And for heparin, there is also an antidote, which is protamine sulfate. So P for P, heparin, protamine sulfate. Those are the antidotes. So if someone has a value too high or they're bleeding and we need to stop the bleeding and it's a very serious issue, we can go ahead and give antidotes for these, which is very nice. Now, alteplase, we're just going to touch on that. That is a clot busting medication. This is what we give to break down this fibrin to make this clot start to go away. There are a couple of clot busting enzymes, alteplase, connectase. This is a very dangerous drug, only given in very serious situations to break down a clot. So these do not break down a clot, the heparin and the coumadin or the Lovenox. They help prevent the clot from becoming bigger so our body can work on dissolving the clot itself. Whereas alteplase, otherwise known as TPA, I've already mentioned TPA, it's in our body, actually breaks down the clot itself. It's a clot buster. So here's some labs. As you can see, we've got PT here for coumadin and INR. So it's an INR is a standard measure of the prothrombin level. So it's a standard measure of the PT levels. And this is what we use to dose. Okay. The others, heparin, it does have low molecular weight heparin, so that would include Lovenox. However, it's not very accurate for Lovenox. Is PTT. That's what you're going to see the most. There's some little cartoons here for you to remember which lab goes with which medication. So the top two there that you can see, which are hands. So we have 10 fingers. So heparin and PTT, you can put them all on your fingers. It adds up to 10. Coumadin plus PT also adds up to 10. And then you just need to remember that PT is measured with INR. Clot dissolution. So remember, our own bodies do this. Our own bodies do fibrinolysis. So what's interesting about this is that our endothelial cells secrete prostacyclin and nitric acid. What they do is they actually prevent platelet aggregation. Okay, platelet aggregation, that's what we don't want, this platelet aggregation right here. How it does that is it causes vasodilation. So it opens up, if this is the blood vein right here, it causes the vein or the artery to open up wider. It dilates, it gets bigger. If it's bigger, if the tube is wider in diameter, then blood is going to be able to flow through it better. And there's going to be less room for a clot to completely block that vein. Okay, so it helps it stay open for good blood flow. And then thirdly, it causes fibrinolysis. So if we take a look at this picture, we've got our blood vessels. Here's the endothelial cell, and the endothelial cell secretes prostacyclin and nitric acid. If you take a look here, it actually puts off TPA naturally. Okay, TPA naturally. The plasminogen turns into plasmin, and the plasmin breaks down the clot. Okay. What I was talking about before, see these little webs in here? That's what I was talking about as far as fibrin is concerned. Okay, so by the plasmin is going to break down the clot. Okay. Oops. So we have three substances in our body that act to decrease and dissolve the clot. We just spoke about some of it. I just want to get into a little bit more detail. We have the tissue plasminogen activator. That's that TPA that we were talking about. And remember, you'll see in a moment that we can give TPA through the IV. We have plasminogen, and then we have plasmin. So here is our clot right here. And we want to get rid of our clot. So the TPA, the tissue plasminogen activator, actually activates this plasminogen and turns it into plasmin. The plasmin is what catalyzes the breakdown of the fibrin into a fibrin degradation product, and that degradation product is called D-dimer. Okay, so here's our clot, here's our fibrin, here's our plasminogen activator. We have our plasmin, and the activator turns it into, or plasminogen, which turns it into plasmin, which then starts to do fibrin degradation. Once the fibrin starts breaking apart, this fibrin degradation product, sorry about that, is called a product. It's called a D-dimer. So the product itself from this breaking up is called a D-dimer, and the D-dimer is actually a test, a blood test that we can do. It's called D-dimer to see if there might be a blood clot in your blood. So a blood test that we do to see, oh, let's see, maybe this is a DVT. We have other diagnostics as well, but we can do a blood test, a D-dimer test, to see if there is a possibility of a blood test. And that D-dimer test actually looks at this because this is done naturally. Okay.